Our next speaker is Professor Juan Valle from the University of Manchester and the Christie in the UK. And he will be talking about personalized medicine, what it is and where we are for cholangiocarcinoma. Is this the future?
Thank you very much, Lorenzo. Thanks for the organizers to invite me to cover this important topic. I think it's certainly something that's very important in the clinic, and many patients are asking about it. And thanks to Heinz-Josef for the introduction. So I guess my question is really about defining what personalized medicine is, and where are we at the moment in cholangiocarcinoma? Is this the future? These are my disclosures. Okay, so I want to just take a little bit of time on this slide, which quite nicely summarizes what we mean by precision medicine, because again, I guess it means different things to different people. So if you just figure on the left with this traditional approach, is that we treat all patients exactly the same with the same treatment, and then we know that there are some patients who derive benefit. There are some patients who get no benefit at all, but we also know that for certain treatments, some patients derive more toxicity than others, and we're increasingly learning about how to define some of those patients. Just skip the middle panel for now. Let's go on to precision medicine. So what this really means is that each patient benefits from a treatment that is absolutely individualized. Okay, and that's what we mean by personalized medicine. It's a one-to-one approach. But in order to be able to do that, there's lots of different amount of information that we need, including genomics, lifestyle, preferences, health history, medical records, compliance, some external factors, as well as some kind of companion diagnostics or biomarkers, which we're increasingly moving towards. And we're probably not quite there yet. We're probably still on this middle step, which is stratified medicine. And by that, we mean that we're actually taking groups of people with similar characteristics and treating them the same. So just to go through that in a little bit more detail, we take disease subgroups. So for example, rather than treating all cancer, we're treating patients with biliary tract cancer. And we may want to enrich patients just with intrahepatic cholangiocarcinoma, perihilar, distal cholangiocarcinoma, gallbladder, or ampullary tumors. So we can define then what the parameters are for that patient subgroup to be defined. But we also need to take into account demographic data. So largely, our decision-making process is based on performance status. The fitter you are, the more active treatment you can have. Sometimes patients, unfortunately, are not very fit, and that certainly limits our treatment options. We also need to take into account comorbidities, other medical problems, and other medications that patients may be taking that might interact. So, for example, if somebody's having immunosuppressive treatments for other conditions like arthritis or things like that, that limits the options of treatments that we can give. We also then need to think about some of the clinical features. The stage of the disease. Is it resected? Are we talking about an adjuvant setting? Is it patients with advanced disease? Is it a first-line treatment? Are we talking about maintenance after first line, second line, third line, and so on? So in fact, we are putting patients into strata, which is why it's called stratified medicine. These are very clearly defined groups. We need to also be aware that the patients may have disease-related complications. For example, in cholangiocarcinoma, the occurrence of jaundice or infection, and that may impact on our decision-making process, as well as any treatment-related complications. So, for example, somebody who may have had some chemotherapy may have fairly bad neuropathy after one line of treatment, so that will then affect our decision-making for a second or subsequent line of treatment. We already use some biomarkers, and some of you may not be aware that this is what we do. But for example, in patients who are going to receive 5-FU or capecitabine, we now do background testing for a gene called DPYD, because that then is able to predict if you're more likely to get toxicity from that treatment. We also will be using CA19-9. John Bridgewater asked this morning who uses CA19-9, but this is a biomarker that's very regularly used for monitoring of the disease, mindful that not every patient can make CA19-9. So that then brings us into the molecular subgroups that Heinz-Josef highlighted earlier, and I think this is then bridging across into this more precision medicine approach. So traditional medicine so far has been defined as the use of surgery, chemotherapy, and radiotherapy. I plagiarized this from a lung cancer paper, but in fact you can easily slot in cholangiocarcinoma and the principles all apply. What we want to do is to move towards identifying patients through gene sequencing, but also try and understand which are the patients who maybe benefit from immunotherapy and specific targeted therapies, which then link into some of the molecular testing that we undertake. But this is not a static field. Angela designed this first figure on the left and published in 2020. And even within 2-3 years, you can see we're learning a lot more about the various subgroups. So we keep on refining. There are some new groups emerging. Maybe the frequency of these alterations are not quite as often as we initially anticipated. So, for example, FGFR2 fusions, we initially thought there was around 15 to 20% of patients. The dust is now settling at around 8 to 9% of patients. And so as we get more experience, as we have more sequencing, we're able to get a little bit more confidence into how big these individual subgroups are. And I'm sure that in another 2 or 3 years' time, we'll have an even more detailed map of the various alterations. So why are we getting such different readings? Well, one of the explanations is that the first studies were largely performed in patients who'd had surgery. So clearly this is going to be patients who had earlier stage disease, which may then enrich for a population of patients who have a particular set of alterations. Recently, the group from Barcelona published this particular paper, and this was specifically in patients. You can see here, 98% of patients had metastatic disease. So in the oncology clinic, in the advanced setting, this is the cohort that we're expecting to see. And as you can see in intrahepatic cholangiocarcinoma, IDH1 mutations are present in around 23%. Then you've got ARID1A, BAP1, KRAS, FGFR, 8% here. You saw 9% on the previous graph, right down to some of the rarer ones, BRCA and HER2. But you can also see the pattern is somewhat different if they're extrahepatic, and this may speak to the embryological development that Heinz-Josef referred to earlier. We also have data from the very recent TOPAZ-1 study, which was a large phase 3 randomized study. Patients were allocated to receive cisplatin and gemcitabine chemotherapy, and then either immunotherapy with durvalumab or a placebo. But what we know is that from the biomarker evaluable population, so this was on every patient, but where it was possible to get the biomarkers, this was the most common pattern of mutations. And you can see TP53, CDKN2A, and so on going right down. And in dark, these are the mutations for which potentially we might have some treatment. So sometimes the readings are around 3 to 4%. But if you're that patient, it's very important that you're identified and potentially you can access that treatment. I think the other thing that we learned from the TOPAZ-1 study was to confirm what was previously known, that the patterns within the different entities is quite different. Intrahepatic versus extrahepatic and gallbladder cancer, you can see here nicely highlighted by the differences in TP53 mutations, which were quite different. And so, for example, we know that HER2 amplifications are much more likely to be seen in gallbladder cancer, for example, and IDH1 is much more likely to be seen in intrahepatic cholangiocarcinoma. And we also know that there are some differences between different populations geographically. So this is a comparison of the mutations seen in patients in Asia compared to the rest of the world. And just to pick up one example, for example, here, if you look at IDH1, this isn't seen very frequently in patients in Asia is much more likely to be seen in patients in the rest of the world. So there are some geographical differences, and obviously we need to take that into account. You've already seen this figure from Heinz-Josef, and I think there's a couple of things to highlight here. Speaking to Judith's fantastic presentation earlier on, I think one of the things that we had even in the first version of the ESMO guidelines, you won't be able to read that very clearly here, but it was the integration of clinical trials all the way through. And it's only through participation in clinical trials that we can make this a much more complicated algorithm going forward as we develop new treatment options. But also, in this new version, there's the integration of molecular profiling really at the time, either just before or during first-line treatment, because the idea is that that's then going to inform what we can do in the second-line setting when we need another treatment. It does take time to undertake the molecular profiling, although it's about 2 weeks from the time the lab receives the sample. You've heard from Heinz-Josef, it can take time to get the sample. So, for example, sometimes the tissue has to come from a peripheral hospital to the central hospital and then off to molecular profiling. And in real life, this takes about 4 to 6 weeks. But if you use that time while patients are receiving their first-line treatment, then you've got the information that you need to inform some downstream decision-making. What I'm going to do in the next few slides is just to really to do one slide per mutation, just to quickly show you why it is that we as clinicians are quite excited and keen to offer treatments to various patients. So the first one to focus on is the most common, as IDH1 mutations. So these are the results of a randomized phase 3 study called the Clarity study. Not all of you will be familiar with these Kaplan-Meier curves, so let me just quickly walk you through them. You start off with 100% of patients alive at the beginning, and every time that this drops down, we've got another patient who unfortunately has died. And so what we want to see is curves going up. At this end is good. Down here is bad, because obviously you've got many patients who are then dying from their disease. And what this particular study showed is that if you compare the survival of patients receiving a placebo, that average was around 5.1 months, and that could be doubled to 10.3 months if patients were receiving ivosidenib. So that's the blue curve at the bottom and the dark blue curve at the top. And the middle curve is because patients who were initially allocated placebo then switched over to receive ivosidenib. And you can see that even if you switch over later on, you get a survival benefit, although clearly now we wouldn't give a placebo. Patients would start on ivosidenib. What this was able to do, it reduced the risk of the cancer getting worse by about 63%, and patients receiving ivosidenib, as I've shown you, lived longer. FGFR2 is a different target. There have been a number of drugs in development, so this slide is just trying to summarize an awful lot of work. Again, for those of you who are not familiar with waterfall plots, each one of these bars represents an individual patient, and you start off at 0, and what we do is we do a calculation on what's happened to the scan results. So if the scan has shown that the tumor has got bigger, then the bar goes up. If the tumor has shrunk, then the bar goes down. And we've got very strict criteria for defining which patients have had a response to treatment, which means it must have reduced by 30% or more, which is what that other line is. And in between, we call that stable disease. There's a few things in common with these waterfall plots. There are a large percentage of patients who are deriving a response to treatment. And intriguingly, some of these responses are bigger than we're seeing with chemotherapy. So obviously having a tablet treatment that is switching off the alteration allows you to get a better response than you would expect to have with chemotherapy. The other thing to highlight is that a very few percentage of patients are getting disease progression. This is disease worsening while they're on the treatment. And a large percent of patients who have stable disease, that's this group in the middle. And the other thing we've observed is that when patients do get a response, these are durable responses, so they're lasting for a significant amount of time, which is clinically relevant. Less frequently, sorry, we find BRAF V600E mutations. So this is a smaller group of patients. But this was a very nice study that was looking at a combination of two different ways of targeting this particular pathway in patients who had this particular mutation. And again, you see here this waterfall plot with a large number of patients who've had a response to treatment. In fact, this was around 50% of patients. Just to remind you, with chemotherapy, in the second-line setting, we're expecting response rates of around 10%. So when you're seeing 50% improvement, that's clearly very promising for those individual patients. ERBB2 or HER2 is another very interesting target. I showed you earlier, this is most likely to be seen in patients with gallbladder cancer. And there's a number of different ways to target that. You can use two separate monoclonal antibodies, which is what the MAB stands for at the end, so monoclonal antibody 1 and 2. Or you can use a bispecific antibody, which is a two-pronged antibody. You can use a pan-HER inhibitor, so this is a tablet version, and then you can use antibody-drug conjugates. And I think we're all looking forward to having the first HER2-targeted treatment specifically approved for biliary tract cancer, hopefully in the not-too-distant future. KRAS has been one of these very difficult genes to target. I think it was previously thought to be undruggable until relatively recently. In fact, there are lots of different KRAS mutations, as I'm going to show you, but this particular one targeting KRAS G12C mutation looks particularly promising. You can see here in the data presented that there was a group of patients with pancreatic cancer, so I'm not going to focus on those today. But if you look at other GI cancers, including 8 patients with biliary tract cancer, 50% of those, so 4 out of 8, had a response to treatment. So again, worth looking for these rather rare patients with KRAS G12C mutations. And finally, with immunotherapy, we now know from TOPAZ-1 and Keynote 966 that we should be considering immunotherapy for all patients, and we're now waiting for some of the availability to come through our various countries. But we do know that if we identify patients with mismatch repair deficiency, you can use immunotherapy on its own. So you can use it without the addition of chemotherapy. And these are the results of the Keynote 158 study, which was identifying patients with microsatellite high or a mismatch repair deficiency, which is a very specific abnormality that patients have in their tumor. This shows the results of all patients, but if you just take out the 22 patients who had cholangiocarcinoma or biliary tract cancer, you're seeing response rates here of 41%. And when you get a response, look at the duration, 2.5 years. So this is something that we really need to make sure that we don't miss when we're assessing patients. If you look at the group as a whole, the progression-free survival was rather short. So it's really the reason to use it is to be able to identify the patients who then get a response, and thankfully it's durable when they do have that. There's always a but. There's always a downside. And the problem is that if you block the station in the middle of the London Underground, people will find a way around and eventually they will get home. The same thing happens with cells. So you block a pathway and then you get resistance which can be acquired. And one of the things that we need to really understand going forward is how do we identify resistance. So just using IDH1 as an example, in this particular paper, they were looking at IDH1 mutations in acute myeloid leukemia, which is AML, as well as cholangiocarcinoma. And this highlights the patient with cholangiocarcinoma. So the patient received treatment with ivosidenib during this time frame. You can see here that their tumor size reduced on the scans. That's the tumor. And then at some point, the cancer started getting worse because they developed new lesions. And you can see here, while they were having the ivosidenib, which targets IDH1, the IDH1 was going down, and then you suddenly start seeing the emergence of IDH2. And so it looks like IDH2 is one of these escape mechanisms from IDH1 blockade, and you can see here that the mutation is present on progression, and it wasn't present on pre-treatment. Let's look at FGFR. Again, we see this same story. So just to walk you through, this is an individual patient. They had tumor and circulating tumor DNA, so a tumor biopsy and a liquid biopsy done at baseline. This is their best scan. And then at the time that the cancer gets worse, you can see here in red, green, and blue, new mutations have developed. And you see this in a second and a third patient. And so one of the things that we've learned is that in these patients, all three develop secondary FGFR2 mutations. But in fact, sometimes you get multiple mutations, and what we need to try and understand is how do we target these going forward. And it may be that we can overcome this by using slightly different inhibitors, and we're now in the era of second and third generation FGFR inhibitors. So my take-home messages are that conventional treatments certainly are here, and we do already do some stratification in terms of patient selection. The emergence of molecular subgroups is really expanding the treatment options, and I think this list is going to hopefully get longer with future years. But as clinicians and patients, we need to make sure that we understand and do the research to know what's the prognostic significance of these mutations, what's the impact of prior or post-study treatment, which patients don't benefit at the beginning, have primary resistance, and how is secondary resistance acquired, and also thinking about rational combinations so we get the best out of our treatments. And with that, I thank you.